Hello everyone. Continuing with the quick review series, today we'll be discussing about the management of gout. So let's start with acute gouty arthritis or acute gouty flare. So in acute condition, we have three most important drugs that has to be used in cases of acute episodes. First one is NSAIDs, then steroid, then colchicine. All of them are through anti-inflammatory measures. Okay. So NSAIDs like indomethacin, like ibuprofen, celecoxib, naproxen, anyone can be used. Similarly, steroids mostly we use parenteral steroids or intra-articular steroids. So either you can use IM or IV steroid, or even intra-articular. Intra-articular steroid also can be used. Colchicine, usually the starting dose is 1.2 mg per oral start, followed by 0.6 mg after 1 hour. After 1 hour, then it depends on the response how much you want to continue colchicine. Colchicine can be given at an interval of 1 hour and so on. And you have to see the response or you have to see the side effect of the colchicine. The side effect of the colchicine is diarrhea. So till the patient develops the response, you can continue giving colchicine every 1 hour or till the patient develops the side effect that is diarrhea. Colchicine is metabolized by P-glycoprotein, P-glycoprotein or multi-drug resistant protein 1, MDR1 in liver, small intestine or kidney, or CYP3A4 enzyme in liver. So any factor that affect this P-glycoprotein is a pump, is a flux pump. MDR1 is also a pump. So either this colchicine is handled by these pumps and this enzyme CYP3A4. So anything that affects these things can also affect the colchicine levels. But there is one more drug, though not commonly used in India for this gout, is anakinra. Anakinra is useful because the primary cytokine in case of gout is interleukin 1 beta, and anakinra is interleukin 1 inhibitor. So anakinra can be used. But the most commonly used ones are NSAIDs, steroid, and colchicine. So these are the drugs used in acute gouty arthritis. Then we will study some drugs which are used as urate lowering therapy. So the risk factor, we are reducing the risk factor. Okay. So urate lowering therapy can be of two types. One is which is causing decreased production of the uric acid, and the other ones are which are causing increased excretion of the uric acid. Okay. Remember, these urate lowering therapies are not used in cases of acute gouty arthritis. Urate lowering therapies are not used in cases of acute gouty arthritis. Acute gout, they are not used because they will cause flare up. They will cause flare up. How? If they suddenly reduce the uric acid levels inside the serum, the uric acid that is deposited in the top five, they will get released. Okay, so if you cause acute reduction in the uric acid level in the serum from the tophus, the uric acid crystals will come into the serum and they will cause more and more inflammation. So that's why in acute gout, urate lowering therapy are not used. Before going into the what are the urate lowering therapies, you should understand that our target uric acid level in this kind of patients, gout patients, is 5 to 6 milligram per deciliter. First of all, we should try some non-pharmacologic therapy. Non-pharmacologic therapy. This includes non-pharmacologic therapy includes decreased alcohol, red meat consumption, decrease alcohol and red meat consumption, decrease fructose rich diet consumption. Okay, and after using these non-pharmacological therapies, we have to go for if still the uric acid target uric acid is not achieved, then we have to start with the urate lowering therapies. But apart from that, there are certain indications where you have to start urate lowering therapy definitely. Okay, this include uh, chronic gouty arthritis, chronic gouty arthritis, subcutaneous tophi, or uric acid stones, or more than equal to 2 episodes of acute gouty arthritis in 1 year. More than equal to 2 episodes in 1 year. So these are like definite indications to start urate lowering therapies. Okay, definite indication to start urate lowering therapies. Okay. Now, what are the drugs that cause decrease in production? The most important one is allopurinol. Allopurinol. Allopurinol is xanthine oxidase inhibitor. Xanthine oxidase inhibitor. The usual starting dose is 100 mg OD. 100 mg OD. You can increase the dose up to 800 mg OD. 800 mg OD. In patients with renal failure, you have to be very cautious. Patients with renal failure, you have to be very cautious. If there is mild to moderate renal failure, start with low dose. Gradually, you can increase the dose. But if there is severe renal failure, better to avoid. Better to avoid. What else? This allopurinol can cause scar. What do you mean by scar? Severe cutaneous adverse reaction. Severe cutaneous adverse reaction. Severe cutaneous adverse reaction. Now, this can be in the form of Stephen Johnson syndrome or toxic epidermal necrolysis. What are the risk factors for developing this if the patient has CKD, chronic kidney disease? If the patient has a HLA type, that is HLA B5801, then also there is an increased risk if the patient is elderly or if it's a female. It's a female. So these are all the risk factors for developing severe cutaneous adverse reaction in patients taking allopurinol. This HLA is very important. HLA B5801. Okay. And one more point is, I forgot to tell in my lecture on management of myasthenia gravis that if the patient is taking azathioprine, if you give allopurinol, then there will be toxicity of azathioprine. So patients on allopurinol, if you want to give azathioprine, you have to always reduce the dose of azathioprine. So that you have to remember that azathioprine and allopurinol better to avoid simultaneously. Okay, don't give allopurinol and azathioprine simultaneously because allopurinol will inhibit the metabolism of azathioprine and it increases the toxicity. So what other drug can be used in cases of renal failure or in the patients having this HLA? The drug is febuxostat. Febuxostat. This is also a xanthine oxidase inhibitor and this can be given in patients with renal failure. This is slightly safer than allopurinol. So can be given in patients with renal failure. Can be given in patients having HLA B5801. So these are about the drugs that decreases production. Now we'll see what are the uricosuric drugs. That means they increase the excretion of the uric acid. First one is propanacid. Propanacid increase the urinary excretion of this uric acid, and the dose is 250 mg PD. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. 3 gram per day. 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 gram per day. You can increase it up to 3 But it is not useful. It's not useful if the serum creatinine is more than 2 milligram per deciliter, it is not useful. In those cases, in these cases, we can use bench bromaron. Okay, so probenecid, maximum 3 gram per day can be used, but in cases of in cases of renal failure where serum creatinine is more than 2, it is not effective. So you give bench bromaron. What are the other uricosuric drugs? What are the drugs that are used for other condition, but they have some uricosuric nature? These include among the antihypertensives, there are two drugs you can remember. One is amlodipine, another one is losartan. Similarly, anti uh, hyperlipidemic, hyperlipidemic. This include fenofibrate, and anti-diabetic, SGLT2 inhibitors. So these are some of the drugs which are used for other conditions, other common comorbid conditions. They also have uricosuric properties. Amlodipine, losartan, fenofibrate, SGLT2 inhibitor. One more point I forgot to tell here. In non-pharmacological treatment, also you have to write that you have to avoid using diuretics like loop and thiazide diuretic, because these drugs cause hyperuricemia. These are commonly used drugs that can cause hyperuricemia. Okay. So probenecid, benzbromaran, and we have read some other drugs which are used for other comorbid conditions that can have uricosuric effect. Also pegloticase, recombinant uric acid. This also have uricosuric effect. Rasburicase and pegloticase has uricosuric effect. Rasburicase. However, rasburicase is not used for gout. This is used for TLS. These two are recombinant uh, uricase or urate oxidase. Rasburicase is used for TLS. Pegloticase is used for gout. Okay, so that's all about the drug therapy of gouty arthritis or acute gout and chronic gout. But and should know that the target is 5 to 6 milligram per deciliter. Target uric acid is 5 to 6 milligram per deciliter. And I already told that never use these drugs, never use urate lowering therapy in acute episodes. So that's all from this lecture. Do read this topic from Harrison.